Hello, my name is H Wang, and I'm a neurologist and researcher who takes care of patients with nerve and muscle diseases at the University of Washington. My goal is to talk about facioscapulohumeral dystrophy, or otherwise known as FSHD. In this video, I will be talking about the clinical features of FSHD and specifically its history in medicine. The first description of FSHD was in 1862 when the famous French neurologist Duchenne published a photograph of a typical case. This is what he described in 1868. He talked about a disease that consisted of a progressive fatty muscular atrophy of childhood beginning around the age of 5 to 7 years, affecting the face or causing atrophy of the muscles, mainly the orbicularis oris and the facial muscles. After a stationary period of several 2 to 3 years, it invades the limbs and trunk, or it works in the same way in the adult. That is to say, it follows a downward march by first attacking the muscles of the upper limbs and trunk, and then extends to the lower limbs in a fairly advanced period. Here, we have a description pictographically of what Duchenne was describing. In 1885, two other French neurologists, Landouzy and Desjardins, published the first case history of a patient that fit Duchenne's description, with facial weakness at 3, shoulder girdle and upper arm weakness at 17, with subsequent trunk and pelvic weakness before the age of 24. And that is why in the literature, this disease is also known as Landouzy-Desjardins syndrome. So what are some of the clinical features of this disease? It is the third most common muscular dystrophy, affecting about 1 in 15 to 20,000. The age of onset is variable from presentations at birth to late life. 95% of patients show some kind of weakness by the age of 20. Classically, the disease presents with facial, proximal arm weakness with wing scapula, followed by weakness of foot dorsiflexion and hip girdle muscles. Meaning that later in life, patients can develop weakness of the hips in terms of sitting up, as well as the foot in terms of dragging their feet and potentially tripping on their feet. Let's go through a series of photographs of a classic presentation of the disease. Here's a gentleman with facioscapulohumeral dystrophy, and here we can see that he has some shoulder weakness in terms of difficulty raising his arms and a sloping shoulder. If you look at his arms, you can see that his biceps are atrophied, suggesting that there's weakness there. And that is the humeral part of the facial-humeral muscular dystrophy. In his back, you can see that he has scapular winging, and that the thinning and atrophy of the muscles pulling in his scapula have resulted in his scapula being protuberant in his back. Unequal and asymmetric involvement is fairly frequent in this disease. Bulbar, extraocular, and respiratory muscles tend to be spared. This means that patients tend to not have problems with swallowing, seeing double, or breathing. However, 1% of patients develop some sort of respiratory weakness. In 20% of patients, their weakness results and then becoming wheelchair dependent. Typically, the symptoms of facial or scapulohumeral, meaning wing scapula or arm weakness, is on presentation in 70 to 85% of patients. However, there are definitely patients that don't present classically, and there's no facial involvement in 6 to 18% of patients. This disease usually only affects muscles in patients. However, there is a form of this that affects children, the infantile form. It is more severe and can affect other systems. However, this disease is predominantly a progressive muscle disease. This video is brought to you by the University of Washington Paul D. Wellstone Muscular Dystrophy Cooperative Research Center that is funded by the National Institute of Health. And we also thank the Friends of FSH Research for the collaborations in this video and many of our research. Thank you.